Good evening. This is the Community Coalition Conversation, and we are talking tonight with Dr. Gary Rhule, and the topic of conversation will be complications of COVID. I'm going to turn the discussion over to Dr. Rhule. Thank you.
Okay.
Thank you, and I'm going to share my screen. Okay, so can you see the screen?
Yes.
Oh, excellent. All right. So tonight we're going to be talking about long COVID. Welcome, and to everyone, good evening and welcome. I am Dr. Gary Rhule. You've seen a couple of these slides before. This is what the COVID-19 virus looks like with the spike proteins that by now you probably have heard about. And so the plan for tonight is to talk about long COVID for about 30 minutes. And then I'll talk a little bit about the vaccines that's out, and then a Q&A and open discussion for about 20 minutes, and then where can I get more information. Just to kind of update you, as you probably are aware that both the CDC and Johns Hopkins University post basically daily both infections, deaths, and recovery. And I just wanted to highlight that for folks just so you understand where we are as of today, February 8th, 2021. Across the globe, 106 million infections, 2.3 million deaths. In the US, 27 million infections, and we are at 463,584 deaths. In Connecticut specifically, 146,000 persons infected. The tests that have been done are about 6 million, and we've had about 7,000 persons dying from the infection. And I put in here the recovered rate of about 9,800. For Hartford, infections 65,000, deaths 2,178. The one thing you must realize is that because of, there's always a lag in the data. So some of the data that you look at both at the federal level, at the CDC and Hopkins, sometimes if you look someplace else, the numbers don't kind of jive. And that's why the recovered rate specifically, because sometimes we don't get that number specifically, and I couldn't find the number to really talk about the number of persons that are recovered. But in terms of long COVID, I wanted that number to be there, but for tonight, we'll just focus on the numbers in Connecticut. So 146,000 persons infected, and the recovered 9,800. And we realize that there's a lag in that number. All right. One thing you should also realize when we talk about COVID, and I wanted to just start with this slide to talk about the risks specifically for persons who are Black or African American and non-Hispanic. So in terms of the risk, right, in terms of the infections, that's the cases, that's the first line that you can see. For persons who are Black or African American, the risk is about 1.4 times the average. Hospitalizations are about 3.7 times, almost 4 times the average. And death from this infection about 2.8 or 3 times what the average person is seeing. And so I wanted us to just focus on this slide for a second. Persons who are Black or African American, for death, we are 3 times as likely to die from this infection from the majority culture. And for being hospitalized, almost 4 times. So just kind of keep that in mind in terms of the risks that we have. What is COVID-19? I'll go through this very fast because you've seen this already many, many times. Of course, it's a severe acute respiratory syndrome, coronavirus 2, also called SARS-CoV-2. It's a virus that causes COVID-19, and it's an RNA virus. When we started with the infections last year, most of this global map didn't look like this. But if you can kind of see in the US on the left-hand side, that deep burgundy, both in the mainland US as well in Alaska. Russia, India, Brazil, Argentina, those places, if it's that deep Burgundy, that's basically saying there are lots and lots of infections, and we really have the highest infections across the globe. This slide just talks about where most of the deaths have occurred, and I won't read through them, but you can see from 1 all the way down to 10, the US, Brazil, Mexico, India, and the UK really has the highest number of persons, both in terms of cases, as well as the persons who have experienced death from this infection. Okay, now we'll talk a little bit about what does it mean when we say long COVID. It's really just short for the long-term effects of COVID infection, COVID-19 infection. And these symptoms can persist for a long time. Some people are saying a month, 2 months, 3 months, 6 months after their infection, they're still suffering from some of the symptoms that they have. And we know right now the virus can damage the lungs, the heart, the brain, and this obviously increases the risk of long-term health problems. Specifically, some of the symptoms are fatigue, shortness of breath, cough, joint pain, and chest pain. And this is after you've actually had COVID, have gone through the recovery, and 1 month, 2 months, 3 months, even 6 months later, folks are still describing these symptoms. Other symptoms are muscle pain or headache, faster pounding heartbeat, a loss of smell or taste, memory, concentration, or sleep problems, rash or hair loss. And I'm going to talk specifically about 3 organ systems that we see are affected. We know that the heart is affected long-term, so this is long COVID. And we know that because imaging tests taken months after recovery from COVID-19 have shown lasting damage to the heart muscle, even in people who have experienced only mild COVID-19 symptoms. So even if you've not been hospitalized, even if you had mild COVID-19 symptoms, there is evidence that there's damage to the heart and the heart muscle. And this presents an increased risk for us for getting heart failure or other heart complications in the future. Another organ system definitely that's affected, as you know, is the lung. The primary infection point is typically the upper respiratory and the lower respiratory tracts, and persons get pneumonia. And really what happens is that this can cause long-standing damage to the tiny air sacs in the lungs. These are called alveoli. And as your body tries to fight the infection, you can have scars that's there, and this can lead to long-term breathing problems. Then in the brain, even in young people, we've seen persons who've had COVID-19. It's caused strokes, seizures, something called Guillain-Barré, which is a condition that causes temporal paralysis where you can't move your hands or your legs. And it also increases the risk of developing Parkinson's disease and Alzheimer's disease. So these are 3 organ systems that we're really concerned about with COVID: the heart, the lung, and the brain. The other issue really is around what we've seen are blood clots and blood vessel problems. So COVID-19 can make blood cells more likely to clump up and form clots. Large clots can cause heart attacks and strokes. Much of the damage from COVID-19, though, is believed to stem from very small clots that block tiny blood vessels. These are called capillaries in the heart muscle. Other parts of the body that clots can be seen are in the lungs, in the legs. I think you heard about a young person, an actor who initially had some amputations because of clots in his legs, subsequently expired. You can also have clots in your liver and in your kidneys. So COVID-19 is not something to play with at all. It can weaken the blood vessels and cause them to leak, and this potentially has long-lasting problems with the liver and the kidneys. After a while, I'm going to stop so you can ask me some questions before I go on. Long COVID again, problems with mood and fatigue. People who have severe symptoms of COVID-19 often have to be in the hospital intensive care unit. They're on a ventilator to help them breathe. And some persons are describing developing post-traumatic stress syndrome, depression, and anxiety. Because it's difficult to predict the long-term outcomes from the new COVID-19 virus, scientists and medical personnel are looking at the long-term effects seen because of the virus that causes severe acute respiratory syndrome and/or SARS. Persons have had chronic fatigue syndrome, extreme fatigue, and they've described just really impacting their physical activity, their mental activity, and none of that improves with rest. And that's been the same for persons who have had COVID-19. Again, it's a new novel virus. Some of the long-term effects aren't completely known, but the organ systems I just mentioned, the heart, the lungs, the brain, impact on your mental health, PTSD, depression, all those things are known, but it's still unknown how much it will affect people over time. And so part of the recommendation is that if you've had COVID, is that your doctor should be closely monitoring you to see how you're doing both physically and mentally, and doing blood work and following you really closely to be sure that we address those long-term complications. Recovery for some folks has really been a long haul. So folks talk about the long COVID, the long haulers, who 6 months after their infections really have not recovered. And many health centers, as you probably know, are opening specialized clinics to deal with all the complications that people who have long COVID have to deal with, both from the physical perspective as well as from the mental health perspective, to help them to be sure that they recover really well. This is really an infection that you don't want. But as a reminder, most people who have COVID-19 recover quickly, but the potential for long-lasting problems from COVID-19 make it even more important to reduce the spread of the disease by following the precautions such as wearing masks, avoiding crowds, and keeping your hands clean. And I'm actually going to stop for a second and stop sharing so that if you have questions, we can talk about them.
One that came up is, where would you place kidney on the list of complications? We are hearing many people end up on dialysis.
Yes, so that is also very high. I'm trying to get back to my screen so I can see you guys. Okay, here I am again, stop sharing. There are a lot of people who have recovered from COVID and have had long-lasting kidney damage and actually have been on dialysis, and there are many, and I can't give you percentage as part of the problem, but we know it's a significant number of persons who have kidney damage and are still on dialysis almost 9 months after their infection. So it's fairly high. So brain, lung, kidney, heart are fairly high. A lot of persons with heart disease might have pericarditis, which is an inflammation of the lining of the heart muscle. So that's a problem. People have had strokes. They've had problems with their memory, long-term problems with their memory. Of course, with the lungs, because as your body tries to fight the infection, part of what it does actually in terms of healing, you may end up having like scar tissue in your lung, and that ends up having complications. So people 6 months later are still on oxygen. So this is an infection you don't want. Before we started, we were talking about the vaccines, and I'll go back and then talk about the vaccines, about why I really highly recommend that it's not only the acute infection that you get infected, you recover, but the significant number of persons who have the long-term complications. And really, it's only been a year, say 14 months. We can't really tell you what's going to happen with all these health effects. But if it's affecting your brain, your heart, your lungs, your kidneys, and your blood vessels, you can be assured that 5 or 10 years from now, you're probably going to end up having some long-term complications that, of course, we can't predict because it's just too new. But it's definitely a problem. So thanks for that question. Any other questions before I go back to my other slides?
I don't see any.
Okay. All right. So let me go back to sharing my screen. And all right. So just another visual of the COVID-19 vaccine with those ugly spike proteins. Okay, so because of, if you followed the series so far, we've talked a lot about COVID-19, the acute infection. We've talked about the mental health complications. Tonight, we've talked about, just really touched on the long-term complications and the significant number of persons who have long COVID or the long haulers, right? So they have symptoms long after the recovery, they're supposed to have recovered in many, many organ systems. So we really need to prevent this infection. And so how do we do that? Obviously, proper masking, making sure the mask covers your nose and your mouth and should fit under your chin. Wearing a mask that just covers your mouth only is not effective. Social distancing, at least 6 feet apart from persons that you're not breathing in their infected air. And as much as possible, if you're in, typically I tell folks, avoid large crowds. If you have to, definitely have your mask on, make sure you hand wash, and these are just proper public health guidelines to prevent becoming infected. You don't want this infection. We talked about the risk in terms of infections for persons who are African American, Black. The risk for us is definitely much higher in terms of getting infection, hospitalizations, as well as death. You don't want this infection. So I'm going to talk about vaccines next. Last month, Dr. Edie really kind of went through all the vaccines. So I won't go into them specifically, but just to remind us that we have at least now, there are 2 that have been authorized for emergency use, right? So there's a Pfizer-BioNTech vaccine that's basically been used since late December, early January. And then you have Moderna, that's also been approved under the EUA, Emergency Use Authorization. And probably in the next couple of weeks, we're going to have another one coming. That's a Johnson & Johnson vaccine that I think they've submitted their data and the FDA is reviewing. And most likely, again, they will get an EUA. This is in the US. In the UK, you probably already know there is the Oxford AstraZeneca vaccine that's not here yet. So for the 2 ones that are being used now, both Pfizer and the Moderna, about 15% of people will experience a fever after the second dose. After the first dose, probably less than 1% will experience a fever. And typically the side effects that you get, if you want to call it that, really, most people will have really at the injection site after the first time, a sore arm, maybe some pain, just some kind of achiness, that tends to go away. That's just a local reaction. You may get some other symptoms in your body. You may get a headache. You may kind of feel achy. You may get some muscle aches and pains, but typically those go away. In the Q&A, if you want me to, if there are questions, we can go back through the specific vaccines I just mentioned, Pfizer and Moderna. But Dr. Edie did a great job with the last time, and that video is on the westindianfoundation.org website if you want to go back through that. You don't want acute COVID. You don't want long COVID. We really need to prevent. You really need to do the vaccine. Just to kind of give you some more data again. So as of the vaccine rollout really started in December, right? So far what we're told is about 60 million doses have been delivered. About 41 million have been administered. The number of people receiving one or more doses is about 31 million. And those receiving about 2 doses is about 9 million. One of the things that's interesting, though, is that this data is, again, there's always a lag in the data. This is from December 14th through January 14th, as reported to the CDC as of January 26th. On this slide, what I want to kind of point out is, so of that number, right, so of that 40, during the first month of the COVID vaccination, where about 13 million persons had their first dose of the vaccine, 63% of those were women. 55% of them were greater than 50 years old. 60.4 were non-Hispanic white. But I put this slide up to kind of bring your attention to of the 13 million persons who had at least one dose, this is in the first month, only 5.4% of them were Black African American, right? And then 2% American Indian, Alaskan Native, and about 0.3% Native Hawaiian or other Pacific Islanders. But for the people that we're trying to reach, specifically the ones who are at high risk, right? Infection, hospitalization, and death from this vaccine, of the 13 million persons who had at least one dose, only 5.4% of us have gotten it. Part of the issue is, you may ask, well, do we have a number specifically for Afro-Caribbean? The way that the data is collected, it's not drilled down at least to that specific number. So sometimes we can't pull out a specific, this is how folks have self-identified themselves, whether they're African-American or of African descent or Black or another race. So that number is really kind of what you are seeing. So I don't have a number specifically for you for Afro-Caribbean specifically, but I would imagine that it's much higher than that 5.4%. So 5%, that's pretty low. Another slide. So where can we get information about COVID vaccine? There are mobile sites, obviously. Rensselaer has one. There are probably others coming. I know a lot of places in the US, they're basically standing up like stadiums. The NFL, I think, says they're going to probably use some of their stadiums to do that. There are many community events. We can talk about that later. There are clinics, the community centers, your local health departments, the community health services, Charter Oak, all the FQHCs are doing it. Hospitals, some pharmacies, CVS, Walgreens, and there are others coming as well. I will leave this to talk about really in the chat because I had to enroll someone who is more than 75 years old for the vaccine, and the system is really, really clunky. And I'm being nice. It's really not an easy way to do it.
What?
Yeah, it's not easy at all. You can call 211 and they will do a registration for you. If you try to do it on VAMS, that I just found to be really clunky, and we can talk about that and get your feedback. I was told today that some providers are reaching out to their patients either by phone call or email to let them know what tier they're in, if they have the vaccine, and when they're going to schedule them for vaccine. So we're kind of really ramping up now, but the 211 system is definitely there for you to call. VAMS, I'm curious to hear about your feedback about what folks are finding. And I think they're kind of ironing it out. Of course, with the West Indian Foundation and the West Indian Social Club, part of the reason why we do this talk is to help you to access the information, and we can help you navigate if you need to. If there are persons who need help, I'm sure there are many persons who would volunteer to help you get registered, whether you're going to try to do that through the call center 211 or helping you on VAMS online. It's not easy. And I think I'm pretty facile with using the computer, and it takes multiple steps. For Hartford specifically, you can also call 311. We talked about 211, and of course your healthcare provider should be also a primary source where you go for information. What are the key takeaways? Prevention. You don't want this infection. Proper masking, social distance, get your vaccine, talk to us, and in the Q&A, let's just chat about how what are the barriers, what are the myths, and just talk about some of the things that are preventing us from becoming infected, from becoming vaccinated. That 5% in that first month, it's just really, really low. And of course, keep up to date with information. You can certainly come to our monthly health series. Pretty much for the last 6 of them, we've talked about COVID. Tonight we talked about long COVID, just to remind you that you don't want this infection. The long-term complications are really, really horrible, and we have to prevent it and become vaccinated. And I think that's the end of it. I'll stop sharing and take questions.
Here's some that came in. What if someone has COVID and does not know because they don't have symptoms and get the vaccine simultaneously? Does this affect the effect of the vaccine?
No, you can still get the vaccine if you've had COVID and don't know, because really they're not going to draw any blood work to see if you've had past infection. So, and there wouldn't be any reason to believe that you could not take it. So you can take the vaccine.
Okay. What are the causes for the increased fever with the second doses?
Okay, so the way that I kind of heard someone explain it, which I thought was really interesting, was after you get the first shot, what it basically does, your body primes your body and makes the antibodies for the infection. And so it's like going from kindergarten, where you're not infected, to middle school. So what that first vaccine does is it allows your body to get primed, recognize the spike proteins as being foreign, and then your body then makes the antibodies of things to fight the infection. So the next time when you're being injected with this foreign protein, right, your body recognizes as being foreign, and it's like moving you from kindergarten into high school. So now you're in the big leagues, and you're going to get that reaction because it's able to recognize this thing as truly being foreign to you and is reacting to the fact that you're seeing it the second time. So it's really just basically that's why you're really getting the symptoms, the fever and the achiness, because your body's really primed for it the second time. And those symptoms should go away.
Okay. Another question is, are we going to church communities to give these talks? And I'll let you answer, and then I can also respond as to what the social club is doing.
Right. So, if you listen to with the new administration, right, if you're really trying to get 100 million doses in 100 days, that's like doing 1 million vaccines every day. So you have to just think about where people go for information. Obviously to this website, the West Indian Social Club, the West Indian Foundation, the health series, we post them there. Anywhere where people go for information, faith-based organizations, sports club, schools, your local health department. If you're going to really get that many people vaccinated, that's what you have to do. And so if you're asking, have we gone specifically to the faith-based ones? I haven't, but I'm sure we have, and we will.
And we've included some of them in our distribution And Bev, do you want to talk about the partnership with the City of Hartford?
Well, there's what we're calling COVID-19 meetup to provide information. Right now, it's spread around the City of Hartford with the various organizations. Unfortunately, I don't have the list with me. Churches are on the mailing list in terms of what we're physically mailing. But part of the challenge, a lot of churches are not having in-person sessions, and they have really seen a decline in participation within the church. What would be extremely helpful, because we can mail, but we don't have a good mailing list for residents of Hartford or the surrounding communities, for that matter of fact. So maybe that's a barrier we need to look. How do we penetrate that? How do we get to the residents of Hartford?
And the other thing is, even if you send an invitation to an organization, you don't have any way of knowing if that organization distributes it to its membership. So even if we invite a church and send the invitation to a church, we don't know if the church distributes it to its membership. Okay, there were not any other questions in the chat. So I'll open up the floor to questions.
So I just have a comment, and just to draw us back to that slide where it shows that we are 3.7 times persons of African American, Afro-Caribbean, Black descent. We really have the bulk of the infections, and we have experienced the bulk of the death from COVID-19. And probably like you, I know a lot of persons in the prime of their life who've lost parents, the breadwinner. That has an economic impact in addition to the other relationship, social impact that it has on persons. And so I don't shy in telling people, really, you need to take this vaccine, right? So there are two vaccines that are out there now, Pfizer and Moderna. Johnson & Johnson is coming, and you probably have heard there are like 150 companies working on the vaccine. You may have some concerns, and I know people have some concerns about they don't want the mRNA vaccine because they believe it's going to alter their genetic material or alter their DNA. It doesn't do that. But I think you'll find that there'll be a vaccine that you're comfortable taking. Johnson & Johnson's vaccine is a killed vaccine. It's not a mRNA vaccine. There is a vaccine, I think, no matter what you may feel, even after you hear all the information, there will be a vaccine that's right for you. And the only way we stop this thing from having these multiple strains that you're seeing, the UK strain, the Brazilian strain, the South African strain, and you can really just imagine it's already here. If we don't get this under control, you're going to have the virus basically just replicating, and every time it replicates, there's going to be a variant that comes. There's probably going to be an Indian strain. There's probably going to be one from Australia. We have to get this thing under control. And you really can't do that fast enough except by vaccinating everybody. Because if you just take the philosophy and the strategy that, you know what, let's just get all infected. And I think I've said this before, if we do that, that means a lot of us from the Caribbean, African Americans, we are going to be the ones dying. We're going to be the ones dying. And I don't think we can do that. We really have to get this infection under control. And the only way you do that is if, as you probably have heard, we need at least 70 to 80% of the global population to be immune. And The way that you do that is through a vaccine. I don't think and I wouldn't recommend that we just let this infection just rip through the society. As a Black person, that means I'm at risk both for the infection, for hospitalization, and for death. I just think that number is just, for us, it's unacceptable. That's my 2 cents.
Okay. There's another question. With the long-term complications, and we're still in the middle of the pandemic, how do you see the medical community surviving and thriving?
You know, that's a great question. I mean, you hear a lot of the healthcare professionals who are at the front line, they are burnt out. No one, I mean, I did emergency medicine. When you have that constant onslaught of persons who are really sick in the ICU, dying, you have persons who can't see their loved ones. They can't, they're there for 2 months and they can't see their loved ones. They can't go to the ICU. They can't hold their hands. They can't communicate with them at the end of life. That's terrible. There's no healthcare provider, none. And I did ER, and you're used to seeing that. When you're seeing that repeatedly for 12 months, you also suffer from PTSD, depression, and anxiety. It's wearing on healthcare providers. It's wearing on families. It's wearing on children. I mean, we're seeing the effects of young kids, right? Adolescents, just the mental health strain, increased suicide, increased depression, increased anxiety, increased drug use. So yes, the healthcare folks, it's definitely a strain. We're all suffering. And if we don't get this thing under control, you're going to burn out the healthcare providers. You'll have no one to take care of you when, a year from now, when you need to have when you need a healthcare provider to put you on a ventilator. So we have to get it under control.
I know at one time they were talking about shortage. One time they were talking about not enough people to do the vaccines. Can you provide a status as to where we are?
Right. So what has happened both at the federal level and many state levels, they are asking for retired healthcare professionals, both physicians and nurses, to volunteer to come back into the workforce to help them to get folks vaccinated. Because really, if you're trying to do 1 million a day, you just can imagine the current workforce is helping with the acute infections. So persons who are retired are asked to come back into the workforce to do that. And they're actually waiving the fact that if you had a license in Connecticut, you can actually do that work in any state basically across the nation. So they're relaxing the requirements. You also have pharmacists who have been trained to do vaccines, but they're also allowing those persons to do that as well. So really, typically any healthcare provider, right? A pharmacist, an LPN, an RN, a doc, retired or not, to come back to help. They're also training persons who have an interest, medical student, nursing students, they can do the same thing. But the only way you're going to get that many people vaccinated is you need to ramp up the workforce, so to bring the retired folks in as well as folks who are in training to do it.
Okay. There's another question. Do you know if vaccine sites will include local community centers?
Yes. So there are a couple of centers that have done it. The local health department, the Hartford Health Department, is actually online. Both Bloomfield and Windsor community centers, you can actually get your vaccines there. Of course, you have to register because it's by appointment, right, to be sure they have the vaccine for you. The clinics will have them. Most of the providers you have to call and ask because they might not have the capacity to do that, because the 2 vaccines, as you realize, requires significant refrigeration, right? So not every doctor's office can do that because they can't appropriately keep the vaccines refrigerated or actually, yeah, at the right temperature. But pharmacies, clinics, your community health centers, they can do them. When you go onto the vaccine administration management system, it will list a whole bunch of places that will do it.
Do you know if scheduling will accommodate evening and night appointments, or if it's still like the standard work hours?
When I went online, it's really all Monday through Friday, and it's standard work hours. There weren't any weekend hours being offered at these sites specifically, and I didn't see them going late at night. And I don't think the mobile sites offer, and I'm not sure, just double check, if Rentschler you could go on the weekends. Typically it's Monday through Friday. Yeah, there are a couple of issues really with the registration process. I mean, I think as someone was mentioned before, you know, to call 211, they take the information and they call you back, they try to find a site for you. When I was helping someone, I went directly onto the online to do it. And part of the problem was if you put like a specific zip code is, this person lived in Windsor. So when you put 06095 in, there was a limitation in terms of the number of sites that pulled up. What I did actually, I changed the zip code. So I put 06112. Then I tried to have them find a site within 100 miles of that zip code. And it really popped up more sites for you. But if you kind of limit if you find that when you go into the online registration, if you're finding that by your zip code it's limited, I would change your zip code. Make it generic, make it Hartford 06112, and search like either 25, it goes by like 10 miles, 25 miles, 50, and I think 100. Kind of just expand the search bar, and it will give you a whole list of sites around your Hartford Hospital, St. Francis, the community health centers, the senior centers are there, and of course your local health department. So you kind of have to be able to jiggle and find a site that's appropriate for you. The Windsor site, when I looked at the Windsor Senior Center, the Windsor Health Department, there were only appointments on a Tuesday, but really, so you have to kind of play around with a site and look to see a time that's that fits your schedule. I'm seeing Mr. Chambers. It's complicated. So honestly, I think if we have persons who are, I'm not being biased, but 75 or old, I mean, I'm not 75 and I found it really cumbersome. So if we know that there are persons who are elderly who we can ask will have some challenges doing the online system, I think we need to outreach them and ask them and to help them get registered because otherwise they're not going to get it done. My other thought was is really to have a large mobile van. And so if we had 50 seniors that we know that needs it, rather than them coming to a center, we would just go down Blewells Avenue or Main Street and we know where they lived and we have a visiting nurse, just give them the vaccine, bam, you get everybody, vaccinated like that. But the online system, they're working on it, I'm told, but I just think it's not easy.
They have the age requirements for the vaccines. Mm-hmm. Is it that you're going to be that age in the year, or you have to be that actual age before you can apply for the vaccine?
Right. So the way that it actually works is when you go into the VAM system, the first step really is through the Department of Public Health. So you're going to actually have to go in there and put in your date of birth, and of course your name and your date of birth, and then they verify your date of birth. And it's probably specifically by your date of birth. Okay. Yeah, but when you go in, there's a two-step verification, if you will. The first thing is you go in, you put your demographics in, you put your date of birth in, it goes to DPH, and they're probably pulling that data either through maybe DMV or some other system to verify your name and your date of birth. Then it gives you a confirmation number that says, yes, you're 75 in 1 day. Then when you get that, then you have to then go do another step, go into the vaccine administration and then register. If you do it that way, you need an email. So if you don't have an email, because that's a problem, if you don't have an email, you then have to go create an email, either by creating a Gmail or using somebody else's email account. So then it will tell you, how do you want to be notified? By email or by text? And what I found difficult was, for the process to register online, you kind of need to have two devices. You need to either have your phone and a laptop or an iPad. So what I would recommend is have your phone and your laptop. So do your name, your name, your address, your date of birth, register, right? Because when you're going to tell them to notify you, they're going to send you a second authentication. That's going to come back either to your email or to your text. The problem is, if you don't know how to maneuver to get from the screen you're registering on, to get to your email or to get to your text, especially if you do it on your phone, you're going to lose that registration process. So what I'd recommend is you really need two devices. Do the registration on your laptop or your iPad. Then when the verification is going to come back to say, yes, this is Gary Rhule, yes, he's 75, because they're going to do the two-step authentication, then you can look on your phone in the email to put that number in on the screen on your laptop or the text message. When you're juggling from back and forth, the registration, you're going to lose the registration process. So again, do have two devices when you're doing it.
You know, since these vaccines require 2 shots, do you have to go through this whole process again for your second shot?
No.
Or do they automatically?
No. So typically what happens is after you've gone through the registration process, you've had your first shot. The right then and there, the healthcare persons will ask you, we need to schedule your second shot now. And they'll actually do it for you. Okay. Because they want to, if it's Pfizer, it's at least 21 days out. And then with Moderna, at least 28 days out. So before you leave, they will actually do that registration for you. Unless you say, no, I think I can do it by myself. But they want you to actually do the registration right then and there. And they'll help you go into the system and do it. Once you've gone through that initial registration process, you'll get something that says you have the appointment. Make sure you bring your ID and the QR code. You don't need your QR code. When you go to the appointment, bring your ID. You will have already put in there, if you have insurance, Medicare, whatever it is, they'll pull that information from someplace else. Really all they need is your ID. And of course, bring your insurance card because they'll need that. But they'll tell, when you get the response from the registration, they're telling you bring an ID and a QR code. You don't need all of that. Bring your ID and your insurance card.
Okay, thank you. Errol has a question.
Hi, Gary.
Hey there, how are you doing, sir?
Yeah, can you talk a little bit more about the Johnson & Johnson vaccine that's under review right now? Because we know a lot about the Pfizer and the Moderna. Could you tell us a little bit about the Johnson & Johnson vaccine?
Yeah, so the Johnson & Johnson vaccine is a killed virus. They're basically using a dead virus called adenovirus. This is like the common viruses that gives you the common cold symptoms that you know of. So basically what they've done is they've taken this killed adenovirus, they've injected the genetic material for coronavirus into the adenovirus and packaged it so it's all dead, They give you that, it's just one shot. And then what that thing then does is it makes your cells make the spike proteins, that's a foreign body, to recognize the spike protein for the coronavirus. So dead virus injection, when it gets into your cells, your body's going to make the spike proteins onto your cells. Your body's going to say, hey, this spike protein, this thing is foreign. We got to go kill it. And we got to make antibodies to kill this thing. So then your body makes the antibodies to kill the spike protein. And the next time it sees it, when we see the live coronavirus, just like I showed you, the live coronavirus with all those spikes, it says, hey, I've seen this thing before. It doesn't belong here. Let's kill this thing. And so what your body has are antibodies. It also has special white blood cells called killer cells. It has B cells, it has T cells. These are special white blood cells. So then when you're infected with coronavirus, your body says, this thing shouldn't be here. It tries to kill it. And the good thing with the Johnson & Johnson vaccine, it's one shot. It doesn't require that deep refrigeration that the other two requires. The only drawback you should know that they've said, it's about 66 to 70% effective against coronavirus, the infection, right? But from serious infections and death, we're being told it's 100% effective against death and serious hospitalizations. But you can still become infected because it's only 70% effective against preventing infection versus Moderna and Pfizer at 95%. The good thing, again, I'd say about J&J, the refrigeration is it doesn't require that refrigeration, especially for rural practices in third world, in developing countries where you may not have that deep refrigeration, it's probably better. And a lot of folks probably won't come back for their second shot. So I think it's a good toolkit to have as a vaccine.
Mm-hmm. What's the name? Is it AstraZeneca? Is that the name for it? What's the name for it?
No, Johnson & Johnson.
Johnson & Johnson. So AstraZeneca, I keep hearing about. What is that? Is that another vaccine?
That's another one. That's not been approved here yet. And that's similar to what I just described with it being a killed vaccine, like the adenovirus. So they basically use a vehicle to put the coronavirus genetic material in there. And none of these vaccines are live, so they're not injecting you with a live vaccine.
Okay. I have another question. I know the information keeps changing day to day with the vaccine. Initially, when it came out, it was like you'll have one shot. Like for example, the Pfizer, you get the 2 doses, and it should be a one-time thing. Is it something that we're going to have every year? Or what's the science saying right now? Once you get the Pfizer, you get your 2 shots. Are you done and good? Just like for chickenpox and stuff, are you good, or is there going to be more shots?
That's a great question. I mean, if you just think about like the 1918, 1920 pandemic with influenza, most viruses, once they're here, probably don't go away, right? So you're probably most likely, especially with the fact that we are not being vaccinated, you have all these strains coming up, popping all over the place, most likely you're going to need a booster of some sort, especially as they're saying like with the South African strain, there, again, information suggesting that the Johnson & Johnson, the AstraZeneca vaccine doesn't prevent against that strain, most likely going to need some type of booster going forward. And even with the Pfizer, Moderna, folks ask, well, how long does the immunity last? We really can't tell you. We think it's sufficient, but maybe a year from now, you'll find that it's not sufficient for us and you're probably going to need a booster. But just historically, the way vaccines kind of work, if you just think about measles, mumps, rubella, all of those, some of them need a booster, you're probably going to need a booster at some point. Especially because really for this particular virus, we have not, and if we don't get this thing under control, you're going to have all these strains popping up all over the place. So the vaccine that worked in 2021 is not going to protect you sufficiently in 2022.
Okay, thank you.
So this is something we're going to have to learn to live with in some kind of variation.
I think so. I mean, if you think about influenza, after the vaccine became available in like 1954, every couple of years they got to tweak it, the strains H1N1, H9N9, and based upon the infections that we're seeing, they change the vaccines. And the way this thing is working, I think that's what's going to happen. We're going to need a booster, especially because you have all this vaccine hesitancy. So the longer that people delay and let this thing just like rampantly multiply in all these strains, you're going to need a booster. That's my medical opinion. You're going to need a booster.
Okay, thank you, Dr. Rhule. We've hit the 9 o'clock hour. We appreciate it, and we will see you next month. Okay, thank you.